Neurology quiz number 99. Describe the clinical features, investigations, and treatment of Behcet's disease or NBD. Behcet's disease is a rare but severe vasculitis. It typically manifests as mucocutaneous disease with orogenital ulcers and skin lesions. However, systemic involvement of the eye, nervous system, GIT, cardiopulmonary system, and the vascular beds causes significant morbidity and mortality. Epidemiology. Behcet's disease occurs worldwide, but clusters are found mainly along the Silk Road, which was a trade route connecting China with Japan, India, Turkey, Europe, and the Middle East. The highest prevalence occurs in Turkey, Japan, and Iran. Lower prevalence is noted in North America and Northern Europe. Usually it occurs from 20 to 40 years of age, but it can affect children and older adults. Sex incidence is equal, but male predominance occurs in the Arab populations. Behcet's disease is most severe in young adult men. It is mainly sporadic, but clustering can occur in families. It is postulated to be caused by a combination of genetic and environmental factors. The HLA-B51 genetic marker is found in 60% of cases. This is a picture of the Silk Route, which stretches from China through Iran and Turkey to Europe. Clinical features. Oral and genital ulcers are hallmarks. They are seen in 90% or more of cases. Cutaneous manifestations include erythema nodosum-like lesions, lesions resembling pyoderma gangrenosum or erythema multiforme. Pathology, which is an eruption of a papillopustular lesion at the site of needle injury within 24 to 48 hours, is characteristic, though not specific. These pictures show an oral ulcer on the buccal mucosa with rolled borders and grayish necrotic base, a genital ulcer with yellowish necrotic tissue on the scrotum, and erythema nodosum-like lesions on the legs. This figure shows the pathology test of phenomenon. The pictures are taken at the time when the patient was stuck with the sterile needle, and number 2 shows the area immediately after the stick, and number 3 and 4 show the area 1 day and 2 days after the needle stick with development of a papillopustular lesion. Neurological complications. Neurological involvement or Behcet's disease affects up to 10% of patients. It is classified into parenchymal and non-parenchymal disease. Parenchymal involvement consists of a subacute meningoencephalitis with headache, fever, and malaise at onset. Brainstem involvement is common. It affects cranial nerves, pyramidal tracts, sensory tracts, and cerebellar connections. Parenchymal disease may also affect the cerebral hemispheres, cerebellum, or spinal cord. A subset of patients presents with progressive dementia and ataxia. Non-parenchymal disease includes cerebral venous thrombosis with intracranial hypertension. Some patients present with signs and symptoms of intracranial hypertension without evidence of venous sinus thrombosis, similar to idiopathic intracranial hypertension. Other systemic involvement. Ocular, the eyes are involved in 70%. Manifestations include scleritis, anterior and posterior uveitis, as well as thrombosis of the central retinal artery and vein, and optic neuritis. 10 to 20% report visual loss in 5 years. GI tract ulceration occurs in the mouth, esophagus, and colon, causing fever, abdominal pain, diarrhea, and bleeding or bowel perforation. Vascular disease affects both arteries and veins of all sizes. Arterial lesions cause thrombosis, stenosis, and ulceration, as well as aneurysm formation, while venous disease manifests as thrombophlebitis and venous thrombosis. Other complications include arthritis, myocarditis, and pulmonary hypertension. Pathology. Biopsy of skin lesion shows fibrinoid necrosis of blood vessel walls with endothelial swelling and a neutrophil predominant reaction. Diagnosis. Diagnosis is clinical and can be difficult as there are no pathognomonic laboratory findings. The International Study Group criteria for Behcet's disease, or the ICBD criteria, are as follows. Points are given for different manifestations, and the score needed for diagnosis is 4 or more points. Investigations. High ESR is noted with active disease. HLA-B51 is positive in 60 to 70% of Turkish and Japanese patients, but only 10 to 20% of European patients. CSF examination reveals high proteins, but oligoclonal bands are usually absent. CSF WBC are increased with an initial increase in neutrophils, replaced later by lymphocytes. Brain MRI. Parenchymal disease most commonly shows an upper brainstem lesion that extends down from the thalamus and basal ganglia on one side, and less commonly is bilateral. Lesions are hyperintense on T2 and can enhance. The term cascade or waterfall sign is used to describe the high signal lesion extending from the thalamus and or internal capsule to the ipsilateral midbrain on coronal T2 and flare. Patients may also show hyperintense T2 lesions within the subcortical white matter. However, brain MRI can be normal. MRI of the spine may show a single lesion resembling a demyelinating plaque, which may or may not be longitudinally extensive. Mass effect and enhancement is seen. MRV, venous sinus thrombosis, is readily seen on MRV or CT angiography. This is a coronal flare MRI. The cascade sign appears as a high signal area on the coronal MRI. It extends from the thalamus and internal capsule to the midbrain. The sign's shape resembles a cascade or waterfall, and the margins are often ill-defined. This figure shows a T2-weighted coronal MRI with a cascade sign on the right side and a flare image from the same patient showing a hyperintense lesion within the right thalamus. This picture shows a T2 sagittal MRI showing hyperintensity within the thalamus and midbrain, and a coronal flare image showing bilateral cascade sign. This figure shows MRV from a patient with left transverse sinus thrombosis, showing lack of visualization of the left transverse and sigmoid sinuses. Treatment of NBD. Acute parenchymal NBD should be managed with high-dose glucocorticoids and an additional immunosuppressive agent, such as azathioprine or cyclophosphamide. In one study, patients with severe NBD treated with cyclophosphamide were shown to have longer event-free survival than those who received other immunosuppressives, such as azathioprine or methotrexate. TNF inhibitors such as infliximab or adalimumab can be used as first-line treatment in severe NBD or in treatment-refractory cases.